as we focus on where we are today and where we look in the future in terms of granulomatosis with polyangiitis and microscopic polyangiitis. I would just like to mention first, as far as, again, today's discussion, there is only one approved product for the treatment of these diseases, so all of the other therapies I'm referring to constitute unlabeled uses, and I have been an investigator on some of the trials which I'll be discussing. So as we look at what we're going to be discussing today, the area that I've been asked to focus on is whether conventional agents still have a role in GPA and MPA. And as we look at this question, what we're going to be discussing is what are the current options for treatment and the data for those options. Where do conventional agents fit within the treatment in 2017? And how well did these conventional therapies meet our treatment goals? Well, in understanding this last question, we have to understand first, what are those goals? And we recognize still that these are potentially life-threatening diseases, so protection of patient survival remains our first and foremost goal. But after that, we are seeking to induce remission of active disease, where again, remission would be defined as the absence of disease activity, avoiding disease relapse, where that's a return of that activity after remission. And as we've become certainly more aware of the minimization of therapeutic toxicity. Now, when thinking about the current management of GPA and MPA, the things we have to take into consideration is because of the tremendous growth that has occurred in these fields, we really consider these now chronic diseases where these patients carry the potential for long-term survival. Complicating that is the fact that we still are faced with relapses that can occur in anywhere from 50 to 70% of patients, and the reality that all of the therapies, regardless of what we're talking about, carry the potential for both short and long-term toxicities. And this can have an effect on our decision-making as far as how do we weigh risks and benefits about the use of the different therapies in these diseases. So we'll have an audience response question. Which of the following statements about remission induction treatment is true? A, in current induction regimens, cyclophosphamide is given for 12 months. B, methotrexate can be used as an induction option for non-severe disease. C, azathioprine can be used as an induction option for severe disease. Or D, glucocorticoids are optional with today's induction regimens. Okay, so most popular choice was B, regarding methotrexate. And that was the answer I was looking for here. Methotrexate, certainly a conventional agent, but one that does still have a role that we should think about in terms of an option. So as we look at a schematic as far as our treatment options that are available to us in 2017, we can certainly see that there are plenty of conventional therapies that appear on this schematic. So as we consider as far as about the question of this, what I'd first like to present as far as is some of the information regarding the conventional therapies, and then compare and contrast that with the data regarding Rituximab, which is the biologic therapy we have available to us today. So in looking first at the conventional therapies, I'd also like to further break this down in terms of the different steps of treatment. Induction, where active disease is put into remission, followed by maintenance. So as we look at the induction half of the equation, we can see a few things again related to our ARS question that we just did. When we utilize cyclophosphamide now, this should be used for 3 to at most 6 months. So in days gone past, while it was used for 1 year past remission, that is no longer the case in terms of thinking about minimization of toxicity. We can also see that glucocorticoids continue to appear as a prominent part of treatment in all of our induction approaches at this time. And we can also see, although azathioprine is used as a maintenance agent, this does not have a role in the treatment of severe disease. So our two conventional agents that we have for induction are cyclophosphamide and methotrexate, and these are stratified based upon the presence of severe versus non-severe disease. It's appropriate for us to first reflect briefly on cyclophosphamide, as this was a therapy that certainly changed the outlook for these patients in the past. If we look back on this, it wasn't all that long ago that there were no forms of available treatment, and this was almost uniformly fatal with a median survival time of about 5 months. With the introduction of glucocorticoids, although the survival time improved, it continued to be only just over a year, with fatality still occurring from active disease or severe infections. But that changed with the introduction of cyclophosphamide and prednisone, bringing about the ability to induce remission effectively for the first time. But as we began to get more experience with this and looked at some of the longer-term series from the NIH, as this continued to expand, we unfortunately saw that the relapse rate was higher than we had first anticipated. And we began to see concerning toxicities in terms of opportunistic infections with unusual organisms such as pneumocystis, and also the development of toxicities such as bladder cancer, such that approaches beyond cyclophosphamide were certainly needed. This work also allowed us to appreciate better the spectrum of disease that can occur in GPA and MPA. Ranging not only from the severe manifestations, but also manifestations that, while they require treatment, are on the less severe end of the spectrum. This influences not only patient outcome, but opportunities for treatment decision, whereby methotrexate can be used for the treatment of non-severe disease. These studies first grew out of the early 1990s, and there remained a great deal still of skepticism and concern about its use, prompting this randomized trial conducted in Europe, where cyclophosphamide was compared with methotrexate in people with non-severe disease. In this study of 100 patients, methotrexate was found to not be inferior to cyclophosphamide, thereby providing this as an option for us to consider in these patients. So as we leave the induction phase and start to look at the maintenance phase, we have another audience response question. Which of the following statements regarding remission maintenance treatments is true? A, azathioprine has fewer adverse events compared to methotrexate. B, azathioprine has fewer relapses compared to methotrexate. C, azathioprine has fewer adverse events compared to mycophenolate. Or D, azathioprine has fewer relapses compared to mycophenolate. All right, so a little bit of a split there here. And again, we've got a lot of relapses and adverse events in this question. But the answer I was looking for was the most popular choice, which is that azathioprine has fewer relapses compared with mycophenolate. And again, otherwise, the other choices as far as these are similar. So let's look at some of these data. So as we look at the maintenance side of the equation, again, we can see in terms of our conventional therapies that there have been data with the use of methotrexate, azathioprine, and mycophenolate mofetil. Methotrexate was first explored based upon the encouraging experience in non-severe disease in an induction maintenance approach in an open-label trial at the NIH. And while this again demonstrated that cyclophosphamide could be used for a shorter period of time and it reduced toxicity, this approach was limited to those patients who were able to take methotrexate and therefore not in renal insufficiency or hepatic disease. An option that was available was azathioprine, and this was examined in a very important and first randomized trial in this disease, whereby after induction with daily cyclophosphamide, patients were either continued on cyclophosphamide for 1 year or switched to azathioprine. We can see in this trial, again, the effectiveness of cyclophosphamide to prolong survival and maintain remission, and induce remission, but at the primary endpoint of relapse at 18 months, azathioprine was as effective as cyclophosphamide, therefore providing evidence that it was able to maintain remission without an increase in relapse rate, and also supporting the use of this induction maintenance approach. Now, the next question became, as far as if you had someone that could receive either methotrexate or azathioprine, was there a preferable first choice? And this was explored in a study from the French vasculitis study group, whereby patients were induced with cyclophosphamide, and after achieving remission, they were randomized to either methotrexate or azathioprine, which was taken for 1 year and then tapered off after 3 months. This study was actually designed to look at a primary endpoint of toxicity, and we can see that there was no difference between these drugs. And we can also see that there was a similar rate of relapse between methotrexate and azathioprine. Interestingly, though, 73% of the relapses that were observed occurred after the drug was stopped. But this again provides evidence that azathioprine or methotrexate are comparable in terms of remission maintenance, and therefore can be selected between the patient and their physician as far as which of these may be the best choice for that individual. There was an interesting follow-up study published just last year, which was a 10-year look at the patients that were enrolled in this trial. We can see that those results continued to bear out as far as that azathioprine and methotrexate was similar, and that there was no difference in terms of rate of relapse, adverse events, or damage. But we do continue to see that the longer these patients were followed out, that duration of maintenance, relapse-free survival continued to drop and really again got quite low in both arms. In considering further about this question as far as how long do we continue remission maintenance, there was a study conducted here by Jason Springer, who was mentored by Dr. Villaforte, which was a look at those patients who had received cyclophosphamide followed by either azathioprine or methotrexate. And this compared the duration of remission in those who received short versus long-term maintenance therapy. We saw in this trial that the choice of the maintenance agent did not influence the relapse rate, but those who received longer courses of maintenance were associated with a lower relapse rate over time. So again, the collective data that we have supports that azathioprine and methotrexate are equivalent, but the relapses occur at a high rate once treatment is stopped. Now, the other maintenance agent that has been examined was mycophenolate mofetil, and there was a great deal of interest in this drug. This was examined in a randomized trial following intravenous or daily cyclophosphamide. Patients were randomized to receive either azathioprine or mycophenolate. And what was found at the primary endpoint was that there was a higher rate of relapses seen with mycophenolate as compared with azathioprine, although there was a similar rate of toxicity in terms of severe adverse events. So although mycophenolate does remain an option in those patients who cannot take azathioprine or methotrexate or have relapsed through those, again, I would probably put it third on the list if all three of those are available based on this data experience. So as we shift then as far as reflecting on the data that we have with rituximab, we consider as far as what do we know both in terms of induction and maintenance. So this is our third ARS question. So which of the following statements is true regarding rituximab? A, rituximab is more effective than cyclophosphamide to induce remission. B, induction with rituximab has fewer adverse events than cyclophosphamide. C, there are fewer relapses with rituximab than cyclophosphamide. Or D, rituximab is as effective as cyclophosphamide for glomerulonephritis. All right, so again, a little bit of a spread there. And so the answer I was actually looking for was D, that rituximab is as effective as cyclophosphamide for glomerulonephritis. The most popular choice was B, as far as induction with rituximab has fewer adverse events. And we'll look at the data further as far as why that was not found to be the case in 2 randomized trials. So following the pioneering work by Dr. Specs, who you're going to be hearing from in the case report and open and compassionate label series, randomized trials were conducted, and there were 2 that were published in the same New England Journal of Medicine in 2010. The study that led to the FDA labeling of Rituximab for GPA and MPA was the RAVE trial. And in this study, patients were randomized to either receive cyclophosphamide going to azathioprine or Rituximab that was given at a dose of 375 milligrams per meter squared per week for 4 weeks. This study did enroll patients who had severe disease, although that did exclude those that, again, were the sickest of the sick in terms of rapidly progressive glomerulonephritis with a creatinine of greater than 4, or people who had alveolar hemorrhage requiring mechanical ventilation. At the primary endpoint, which was being in remission and off prednisone in 6 months, Rituximab was found to be as effective as cyclophosphamide. And as a sub-analysis, looking at those patients who were enrolled at the time of a relapse, Rituximab appeared to be more effective. Now, again, getting to the question on our audience response was there was no difference in the frequency of adverse events between the 2 study arms. That likely reflected the fact that high-dose prednisone is utilized in both groups, as the rate of infections was also similar between these study arms as well. This study was associated with a low rate of mortality, but that does provide compelling evidence that for remission induction, Rituximab is as effective as cyclophosphamide. Now, one of the questions, again, that we got to in question D and that was anticipated would be of great interest to people was, what about this disease manifestations as far as the glomerulonephritis and alveolar hemorrhage? And these were looked at in the primary RAVE paper, and we can see that almost half of these patients did have active glomerulonephritis at the time of enrollment, and almost a third did have alveolar hemorrhage. And there was no difference in the frequency of improvement and remission in these manifestations between Rituximab and cyclophosphamide. So this did provide evidence that in those patients that had alveolar hemorrhage, again, short of requiring mechanical ventilation, which was excluded, and again, in glomerulonephritis, short of those with a creatinine of greater than 4, Rituximab is as effective as cyclophosphamide. Now, the other trial that was published in the New England Journal was from the European Vasculitis Society, the RetuxVASc trial. This shared also some interesting insights because of some differences in the study design. We can see this was also randomized, but in the Rituximab arm, these patients continued to receive 2 doses of intravenous cyclophosphamide. And this was also designed as a superiority trial where they were trying to determine as far as whether Rituximab was in fact better than cyclophosphamide. Although the rates of remission were similar between the drugs, again, demonstrating that there was similar rates of effectiveness, it did not meet its primary endpoint in demonstrating that this was more effective. We can again see that the rate of adverse events was similar between Rituximab and cyclophosphamide, but there was a higher rate of mortality, likely reflecting that patients with more severe disease were not excluded, such that the 20% of these were on dialysis, and this was also an older patient group with a median age of 68. Both of these factors have been found to be associated with a poorer outcome in these diseases. So again, this demonstrated that while Rituximab was effective, it was not superior to cyclophosphamide. So we've shown from these studies that this is an effective medication. Does that mean that Rituximab should be used in place of cyclophosphamide to induce remission just across the board in all patients? And the answer is no, not necessarily so. And again, when we reflect on what we know, there is not equally strong data in all populations. And looking at the strength of evidence for use, far and away, certainly the most compelling evidence is in those patients who have relapsing severe disease, while the least evidence, again, was those patients who had been excluded from the RAVE trial that really had truly fulminant disease, again, with elevated creatinines requiring mechanical ventilation. So I think there are settings in which I still personally prefer cyclophosphamide, and again, this is opinion-based as far as in those, again, who are very critically ill in the ICU. I do tend to favor the use of daily administration. People with severe disease who have intolerance to rituximab, and although this is uncommon, we have certainly seen this. Again, another uncommon scenario, and one that is always tricky as far as whether this is truly occurring or whether it's our anxiety as far as whether people are progressing as we expect in terms of worsening severe disease despite rituximab. And again, I think it is still something I do discuss with newly diagnosed patients. I think we're seeing less concern and reluctance with rituximab than what I was seeing after it was shortly FDA approved. But again, there are still certain patients who do have concerns about rituximab such that cyclophosphamide remains something they would prefer to consider. In balancing this, as far as there are also settings where I would prefer rituximab, and I mentioned again, relapsing severe disease, certainly if they've received cyclophosphamide before. Newly diagnosed patients who are at each end of the age spectrum, the young where fertility preservation is important, and also older patients who tend to tolerate cyclophosphamide less well. Patients who have leukopenia or thrombocytopenia, patients who have urinary retention where bladder concerns with cyclophosphamide could increase their toxicity risks. If a patient has had a malignancy history, again, similar to RA, rituximab would be a favored therapy. And in speaking with infectious disease colleagues as far as pros and cons about these agents, they tend to favor rituximab, although again, reflecting that of all of the therapies we use, glucocorticoids is probably the most problematic. And again, for induction of severe disease, that would be necessary. So after rituximab induction, the question becomes, how did they do? And in the longer-term RAVE data, there was no difference between rituximab and cyclophosphamide to azathioprine, but about 30% continued to relapse at 1 year. The factors that were associated with an increased risk of relapse, including a previous relapse, a positive PR3 ANCA, and the GPA phenotype. And this has also been demonstrated in another non-rituximab-based series. So rituximab relapses do continue to occur after rituximab, such that a plan for remission maintenance needs to be considered. And what we know in terms of maintenance after rituximab and the use of that, a study that was published in 2014 from France was the Main-Ritson trial. And after induction with intravenous cyclophosphamide, these patients were randomized to receive rituximab 500 milligrams for 2 doses, 2 weeks apart, and then every 6 months, or azathioprine, which was dose reduced and ultimately discontinued. In this study, we can see at the primary endpoint, which was a major relapse at month 28, there was certainly a difference as far as whereby rituximab was associated with a lower rate of relapse compared with azathioprine. But questions remain in terms of how did the dose reduction impact azathioprine, and what do we do with rituximab after these 18 months? So at last year's ACR, we heard at the plenary session about the long-term follow-up of the Main-Ritson trial, which looked at a 16-month period. Again, we can continue to see the results were borne out as far as that there was a higher rate of relapse in those who received azathioprine. But the longer these patients were followed out after having received the 18 months and rituximab being stopped, you can see that these relapses did emerge over the course of time. So while there were fewer relapses, relapses did continue to occur frequently after drug discontinuation. We also heard at the ACR in the late-breaking session the next phase of this study in the Main-Ritson 2, which compared scheduled rituximab given every 6 months through month 18, compared to rituximab that was given based upon lab-driven results as far as ANCA and B-cell depletion as measured by the CD19 count. In looking at this, what they presented in their abstract was that there was no difference, interestingly, in the rate of relapse between these two study arms. but there were a lower frequency in the number of infusions that was given with the lab-driven timing. So although, again, we're waiting with interest the results from the full publication, again, it's interesting to see how this balance will be in terms of the reduction of, the no difference in relapse, but the reduction in the number of infusions. I just want to mention a couple of other trials that have been of interest to me as far as in maintenance after induction. One was, again, from Rodrigo Cartin-Seba from Dr. Speck's group, as far as the long-term experience at the Mayo Clinic with Rituximab, reflecting, I think, one of the largest long-term experiences with the use of this, where Rituximab was given at relapse or, again, based upon ANCA and B-cell depletion. This did demonstrate that this strategy was effective as far as reducing relapse. And this trial also importantly reminded us as far as pneumocystis can still occur with Rituximab, such that, again, prophylaxis remains important. We also examined the question about what happens after Rituximab in a study here at Cleveland Clinic, where patients, after receiving Rituximab, many of these received use of a conventional agent, and the relapse-free survival was higher in those who did receive that therapy. So the optimal approach after Rituximab induction remains unclear. This is currently the focus of the Rituximab trial, which Dr. Merkel, which you just heard from, is leading together with Dr. Jane. So in terms of the optimal approach to remission maintenance, what can we say? I think we can say from the Manritson trial that Rituximab given for 18 months has a lower relapse rate than azathioprine, but relapses occur if Rituximab is stopped. That's true for conventional agents as well. The problem remains that this is not 18 months diseases, and we have to think about what are we going to look at in terms of the long term. The risk versus benefit about using Rituximab over very extended periods of time remains unclear, as does the best approach to manage long-term maintenance. What are the possible approaches that we have? Well, we could use Rituximab for 18 months and then stop and retreat if it occurs. We could continue Rituximab every 6 months, but that begs the question, how long will we continue that? We could try and lengthen out infusions. Again, no experience from a trial basis for that. Again, we're reflecting on the data as far as retreatment based upon ANCA and CD19, or the question about, is there even a role for a conventional agent after 2 years of Rituximab maintenance? There could also be a strategy as far as not using Rituximab maintenance at all and instead using azathioprine or another agent following induction. And another strategy that some have favored as far as not giving any maintenance after Rituximab and retreating if relapse occurs. And I personally would have some discomfort as far as with this in patients who had had significant damage, but again, that is an approach that has been considered. So again, reflecting on our schematic as far as where do conventional agents fit, again, I think we can see plenty of them that are appearing, and these do remain within our treatment options. Is there a role? I think the answer is yes, but many factors must be weighed in deciding treatment for each patient. In terms of induction, again, we are driven by our data in looking at severity, whether it's new diagnosis or relapse, age, comorbidities, and past treatment history. Maintenance, I think, is more challenging in terms of the degree of uncertainty. And again, we have those same factors. And again, potentially leading intriguingly into questions that Dr. Speck may probe as far as what do we do as far as thinking about ANCA type, phenotype, and the increasing role of genetics and how that may lead to personalized approaches. So in summary, as far as today's therapies, which does include conventional agents, do provide valuable options for the treatment of our patients. And again, looking forward, I think there are many exciting things that we lead on the horizon, but there are many exciting things that we do have available to offer our patients today. Thank you.